Thank you very much for the nice introduction. I want to thank first Dr. Trumberg for the inviting us so that the opportunity to present our recent work, and also I want to thank Sunar for coordinating this visit. So I will talk mainly our recent clinical work with PDT on head and neck patients, and my name is Ulas Sunar. Most of the time this is becoming missed because this is a Turkish character that makes SH sound, and that's Ulas, but it doesn't matter. I just wanted to. So I will, after showing our motivation for our research of head and neck patient monitoring, I will introduce briefly the diffuse optical methods, and then I will show some preliminary work we have done, and mainly jump into, after that, translation the clinical part on monitoring the head and neck patients in the oral lesions. So just a brief introduction to PDT therapy. So we inject the photosensitizer that is being activated at a specific wavelength for that particular photosensitizer, and this specific wavelength activates the photosensitizer, and it interacts with the molecular oxygen, and then it creates a reactive singlet oxygen, and this singlet oxygen kills the cells. At the same time, also destroy the photosensitizer, and we monitor the photobleaching of the photosensitizer as a marker for the PDT efficacy. So for the effective PDT, we need to improve the PDT dosimetry. So for that purpose, we have three components. One is we need to have enough photosensitizer accumulation in the lesion we are investigating. You need to do also nice delivery of the light, and you need to also have tissue oxygen. For this part, we are the one, as an imaging person, we are monitoring these things, and light dosimetry is monitored by the laser engineers. For the tissue oxygen, and our tools, as you are also working on the similar field, generally is the vascular sensitive techniques. So we monitor indirectly tissue oxygenation. We monitor actually blood oxygenation. We monitor blood flow, and we can also quantify oxygen consumption, which are related to tissue oxygenation. So again, why do we investigate the vascular parameters? Because these parameters indirectly affect the PDT response. For example, when you have in this case, I am showing a small cartoon. For example, blood flow is flowing in the vasculature, and then we expect that because of the diffusion from the vessels to the surrounding neighboring cells, around this region will be more oxygenated tissue compared to the outside with the gradient. So when we monitor the blood flow, if we have a good blood flow, then we expect that we will have also improved photosensitizer accumulation. It may also improve the oxygenation, and if we have a blood oxygenation, improved blood oxygenation, we expect also tissue oxygenation is improved. So these vascular parameters also change during therapy. PDT is a very dynamic therapy, and it destroys the vasculature. Most of the photosensitizer are vascular disrupting agents. So if affects the vasculature, it affects the blood flow, and it affects the blood oxygenation. So it is basically all are linked together. For the photosensitizer, actually a lot of people worked already. They showed that even the pre-treatment photosensitizer distribution can be the indicator of the PDT response. So you need to really know how much photosynthesizer you have in the tissue to put correct amount of the light. Otherwise, it may be too much, so that you may not have, so that it may consume too much oxygen, which you don't want that during the PDT. PDT is really very dependent on the oxygenation status. Also, drug concentration continuously change during PDT. We call it photobleaching. So, and it was an indicative of the signaled oxygen generation. So that's why photobleaching is also indirectly indicator of the PDT efficacy. So our ultimate aim, I would summarize, would be so that we want to optimize the PDT. We want to predict the outcome. So if everything goes well, so go with it. But if something is wrong, we want to feedback to the loop so that we can change the dosimetry. So for this case, our photosynthesizer is HPPH. I will describe a bit more detail. So in this case, it introduces changes, functional changes, physiological changes, or oxidative metabolic changes, and also photosynthesizer content. And these changes creates changes, also induces changes in the tumor environment or lesion environment. For example, blood flow, as I mentioned, may change. It is directly related to also blood volume, fluorescence, or drug content and oxygenation. So that we want to monitor these things as a non-invasive markers to assess the PDT outcome. But there are other markers also. For example, there are biomarkers, for example, molecular markers. In this case, I will mention about the STAT3 cross-linking, which is found in our institute by the Dr. Baumann group. So they found out that actually oxidative cross-linking of STAT3 depends on the drug concentration and light dose. So it's basically PDT dose. So that by looking at the tissues and quantifying the percentage conversion of the monomeric STAT3 into dimeric complex, it is directly related to the accumulated PDT dose. And in this here is this, so as an example, so they look at the analysis, and if there is a PDT dose, then they see that there are like bands occurring. And if there is more dose, like concentration, for example, of the photosynthesizer or the light, then they see more. And they look at, for example, this is the patient case. It is quite heterogeneous. So it may be biopsy sampling, or it may be the tissue itself is heterogeneous. But there is a trend that it is increasing with the dose. So this is the previous stuff. So that I want to, so our aim is, as a non-invasive imaging, we want to correlate with the clinical response, and also we want to correlate with the molecular marker. So overall hypothesis, if we correctly characterize our diffuse optical methods, these methods can accurately determine the optical properties, which is good for the correct dosimetry, and also they can assess some functional physiological parameters that may be indicative of the PDT response.
Ulas?
Yes.
Back on that previous slide, is that also related, is the STAT3 conversion, has that been shown to be correlated with extent of necrosis or outcome, or is that more an acute measure of, let's say, lipid peroxidation or peroxidation of molecules by singlet oxygen?
I myself don't know much about, I don't want to know 100%, but they are, I don't believe they look at the depth of necrosis. So they will basically get the sample and some protein analysis. So it will be like an average, average of that tissue sample. So they don't have the, I don't.
So it's a sort of a molecular marker of damage.
Yes.
But that damage may or may not be related to outcome in terms of treatment.
Yeah, they directly related to the dose, but so that this was like in our PO1, this was the hypothesis that this will be a marker, biomarker.
Of life, though.
Yes,
Yeah.
yes. So I will briefly introduce the diffuse optical methods. I know that you already have the background, so I will pass quickly, but of course you may interrupt any time. So the first part is the diffuse reflectance spectroscopy, where we measure the oxygenation status of the tissue, and then fluorescence spectroscopy, where we can measure the fluorescence content so that it's related to photosynthesizer content. And also diffuse correlation spectroscopy, where we measure quantify the blood flow. Why we are doing this methods? We are doing the PDT at the operating room, so we have only about 5 to 10 minutes. So you need to do very fast measurements. You don't have too much time. PDT treatment takes about 15 minutes, so you have about 5 minutes to go. So these techniques are non-invasive, as you know, and the instruments are very portable. So it is very friendly for the operating room. So we can, because it is non-invasive, we can measure many areas. Although it is not imaging, still you can do multiple measurements, so it will be still better than biopsy sampling. And it is so fast that you can have at least like 10 measurements even within a minute very easily. So for the diffuse reflectance spectroscopy, the main, we assume that the contrast is coming from the blood, so hemoglobin. So we have the oxygen deoxyhemoglobin part, the absorbers. We use the white light spectrometer, so we occur the data from 500 to 850 nanometer range. So the main absorption that we find that between the 500 to 600, it's really quite useful for quantifying the oxygen deoxyhemoglobin part. But in our tissue, because of the photosensitizer is also available, so we have for the quantification, we assume that the absorption is the linear combination of oxygen deoxyhemoglobin and also HVPH. This is our drug at around 665. And if you want to quantify also the scattering medium, we assume that it is a me-type behavior. So we have only 3 parameters without Ms prime fitting, oxygen deoxyhemoglobin or an HVPH concentration, or you can also analyze it with the oxygen saturation and blood volume. And if you want to fit also the scattering, then it will be like 5 parameters to quantify from this multivalent fitting. For example, I am giving an example for the one patient case. So HVPH absorption creates a little bit small dip around 665. Then you will quantify absolute quantification of the concentration. For this patient, it was pre-PDT, it was about 0.3 micromolar in the lesion compared to the surrounding normal tissue. Actually, it was most probably, on this case, it was contralateral, not surrounding. Surrounding, we are measuring also periphery. It will be a surrounding tissue. Yes.
You're using a probe?
Yes.
And the source detector separation?
Yeah, I will show that. I'm just trying to get into what we are doing. And the advantages I was trying to say is that you are getting absolute value. You need to have to provide to the MD how much drug you have for this tissue. That is the main aim, and that is the part that diffuse reflectance spectroscopy can provide. It is an absolute quantity. But the problem is, it is really low contrast. It's not really great contrast for the absorption, especially for the drug. So what we do is that I'm trying to motivate you for the fluorescence spectroscopy, is that it is amazingly very nice signal we are getting from the HVPH, this drug, that it is a very high contrast, so that we also measure the diffuse fluorescence spectroscopy for this purpose, quantification of the drug. So for this purpose, we excite. So most of the PDT compounds has a solid band excitation about 400. So HVPH has a 410 peak around here. So we have a laser diode excites the drug. And then we have a long pass filter, about 500 long pass, so we can get the autofluorescence part and also HPH fluorescence part. That HPH fluorescence excitation peak will be around 670. And there is an also important shoulder about 720 that we also make use of this. So we would get the patient data something like this, so autofluorescence part, then the HPH fluorescence. So we most of the time we analyze from 600 to above because of the absorption of the blood is a little bit less. Then we normalize the fluorescence data with the reflectance data to a little bit, to improve the optical properties, affects the fluorescence. That's why we wanted to reduce that effect. And for this one, we want to, like, let's say for pre-PDT and post-PDT. And for the quantification, what we have is that the measured data will be a combination of the HPH with the basis spectra of the HPH and autofluorescence and the basis spectra of the autofluorescence. But this time, C doesn't correspond to the concentration anymore. It is a coefficient, but unfortunately, it's not the exact concentration because it is still affected by the absorption. In this case, for example, we did experiments with the absorption. This is just one experiment, doesn't really representative, but it is still intralipid because it doesn't take out the effect of the absorption and 410 of hemoglobin. But it is improving the quantification, but it doesn't totally improve the absolute quantification of the fluorescence. This is an ongoing research. People are really doing the correct quantification with the fluorescence. For example, this is a nice example why we need this correction. This is from Bargo, from the Steve Jack's group. This is a raw fluorescence. Maybe this was again oral cavity. I'm not sure exactly from which lesion, and after the correction is done, you see a much better contrast. And lesion shows heterogeneity, but normal tissue will be really homogeneous. And then you can get the absolute quantification, concentration of the drug. So this is the ultimate aim. So what you can do is, 410 is really very highly absorbing by blood. So what you can do is you can make use of the 665 excitation of the drug, the second excitation peak, where the PDT light is. So in this one, the absorption, optical blood absorption is much less. And also penetration is higher. And this penetration depth will be also similar to the treatment light penetration. So this may be a better options, which now we are incorporating this also laser so that you can use an optical switch. You can get both of the laser excitation and see the difference also. Now, for the long wavelength excitation, the question will be like whether you can see a signal. It is the less absorption, but whether do you have enough excitation. Actually, it turns out that for HPH, it is more than enough because it's not like a PP9. People over here works a lot on the PP9. In the PP9, this peak versus this peak is like 25-fold. But in HPH, only about a 2-fold. Quantum efficiency of the fluorescence is very nice. So what we see is that when you do exactly 664 around, and if you do 690 long pass or 720 band pass, you can even see through the deep imaging. So we did it on mice imaging, and also we did it on phantoms. We showed that for this particular case with the tomographic setup, which briefly you scan the laser on the source plane with the Galvo scanner, and this is the light source will be on this plane. And then with a CCD camera, we also use the CW CCD. Then you can reconstruct it through the whole tank, and you will be able to see good contrast basically in deep tissue imaging. So now I am switching to the last tool that we are using as a diffuse correlation spectroscopy to quantify blood flow. In this key scenario, we have for this cartoon, we have the black dots as static scatterers, and the red are the representing the moving blood cells. If there is no motion, what we see it in our signal is a kind of a flat signal. But when there is a motion, we see the temporal fluctuation of the intensity. So we are using the hardware correlator, which also gets the temporal arrival times of the photons, and if it automatically gives the also some delays, then it calculates the autocorrelation function. So if everything is static, like when you are sitting on chair, then you would, when you give a delay of time, seeing you on the same place, probability of seeing you on the same place is almost 1. But if you are moving around to get a, let's say, pizza or something, I may sometimes catch you on the same spot, so probability will be decreasing. So if you are moving too much, then the possibility of seeing you on the same spot will be less. So it is the same idea. Autocorrelation function, if decays quickly, then we have a more blood flow, and if decays less, then we have a less blood flow that you can see it on your monitors. For quantification is a bit tricky, but the models is done previously, so that they found it from the Arjun's lab. They found that autocorrelation function is also satisfies the diffusion equation. So it is a static term and also a motion term. The main assumption here is that motion part is one of the like Brownian motion flow model is assumed. This is the empirical observation. They found that the data is really fitting much better with this assumption. And we define the blood flow as an alpha dB. Alpha will be blood volume fraction that you can calculate from the diffuser reflectance spectroscopy, and dB will be the effective diffusion coefficient. So for our motivation for this clinical work, there is already a lot of work, previous work is done by the researcher, including also here. What they found is that from this, again, Arjun's lab, but interestingly, over here also, Dr. Chen and Nelson also worked on this, the continuous measurements. So what they see is that when you do continuous measurements, you see different patterns of blood flow changes. For example, in this case, there is an early increase, then decrease, then comes to the baseline. And what they found is that maybe early response can be predictor of the PDT. For example, in this case, they indeed found that flow reduction rate slope is indicative of the PDT response. If the blood flow decreases too quickly, it is not good. It is also decreases the oxygenation, so you are not providing oxygenation enough to the lesion, so that PDT cannot be really effective. You need enough very good oxygenation status to have an effective PDT treatment. They also measured the 3-hour post-PDT, and they found that both blood flow decrease is correlated with the PDT response, and also oxygen saturation. Oxygen saturation measurement is a lot of people work on that. Even I saw like Brostromberg measurement previous work on this thing. So it is well studied. So what we saw in Roswell is that actually you can continuously monitor, but everything is changed with respect to fluence rate also, and also the site, tumor models. For example, ALA, PP9 is well known that it is not really vascular disrupting agent. It is more like it gives a temporal occlusion, but it can recover very quickly. It doesn't accumulate too much the blood supply, but we saw that as you increase the fluence rate, it is actually you are decreasing the blood flow. But this model was the Colo26 in the mice model. When we did this thing on the patient, it is totally different scenario. So for example, this was his superficial basal cell carcinoma and nodular basal cell carcinoma patients. We see it, and they have the different also treatment plan that's arranged by the MD, and we see a different scenario compared to here. So where the tumor models is different or fluence rate is totally totally different. But at the end, what defines is the protocol. Like we have the clinical measurements at the OR, so we have only about half an hour to go. But in this case, for example, when we look at the HVPH, we wanted to see how the blood flow changes. We see this is the typical PDT dose people are doing for the mice studies. Like they would irradiate 135 joule and then 75 milliwatt per centimeter square. So it is like widely accepted protocol. But what we are seeing is that it's not really good because blood flow very quickly decreases, then increases again, and there is some fluctuation is going on. But when you do low and slow, meaning that you are doing very low fluence rate with an extended period, then actually you are really having a nice blood flow still moving. So you have most probably having also blood oxygen saturation is high, so oxygen level is high. Then gradually, basically, you are killing the lesion in the long term. So this is what you want. Like about after 3 hours or so, you want really destruction, but in the beginning, still you want oxygen to be there.
Ulas, is this done with a long interval between drug administration and light dose, or a short time?
This drug is all accumulates like 24 hours to 48 hours. We always use like a longer, like we wait always 1 day. It's for the same also for patient.
Yeah.
These drugs are generally like long-term accumulation, not like a fast.
So there's significant drug
in the tumor, yes. So it's like a 2 to 3 times contrast in the tumor compared to the skin or surrounding.
And it's localized in cell membrane structures?
There are different mechanisms, so according to what place, but it is, cells localization also. And also,
At the low dose rates, at the very low dose rates, do you see a difference in cell death mechanism?
I myself didn't look into that, but I'm not sure about that. I don't know.
Because they may die differently with less of a major necrotic component and more of an apoptotic component.
Okay. Well, I mean, there are like cell biologists also working on this stuff. Most probably they have done already previous work, but I'm not aware about. I cannot answer that. So now I want to switch to the clinical work. So what we are doing at the clinic is that we translated this HVPH. It's in the phase 1 trial and also multi-center. So with the University of Minnesota, Maryville, we are working on PO1 grant. So we are monitoring the head and neck lesions in the oral cavity. These are superficial tumors. So why do we need, what is the advantage will be for the PDT? Actually, what people saw is that when you do radiation or chemotherapy, really you see a lot of side effects, especially it is very crucial on the head and neck region. So what is the main problem is that you may cure the lesion, but you are really introducing a lot of functional problems for the, like during the surgery you may remove a lot of functional tissue, or chemo and radiation can lead to irreversible injuries that you cannot, the patient cannot recover. So PDT actually preserve functional organs very nicely. We can even repeat this on the same patient like 2 times, 3 times PDT. So it doesn't make really very problematic on the patient. So even one treatment fails, you can do again the treatment. So that is one of the advantages. So generally, the lesions we are looking will be around soft palate, hard palate, and also near to the tooth area or tongue, top of the tongue. That will be the best case scenario, so that it is very easy to reach. It may be side or it may be under the tongue. And about 300 patients actually screened at Roswell, and about 10 to 15 patients will go for the PDT. And we also did already photofrin-based PDT. This is a well-known PDT compound. And we saw that there is a significant skin toxicity, so that we switched to HPH, which has much less skin toxicity. So this is the one of the big advantage for the HPH. So the lesions we are looking is anything like carcinoma in situ, dysplasia. It can be any grade, and T1, but the point it has to be also thickness or depth needs to be superficial, so within 3 millimeter. So protocol will be MD generally do visual inspection, and in suspicion cases they may use the autofluorescence imaging, so that lesion location. So we inject the drug 1 day before the PDT treatment. So during the PDT treatment at the operating room, we do the diffuse optical spectroscopy measurements, then biopsy is taken, then about 15 minutes PDT, then again PDT, our measurements and biopsy. This biopsy is STAT3 cross-linking to see whether there is a molecular marker to see whether the PDT is efficacy. And we want to correlate with our measurements with the STAT3. HPH dose will be 4 milligram per meter square, and PDT dose was the escalated one. Now we are stabilized. It shows about 140 joule, I think, and 150 milliwatt per centimeter square as the optimal for this particular drug. And we generally illuminate the lesion and a little bit surrounding the periphery area.
But did you do a dose rate escalation, or did you just pick a fixed dose rate?
It was a fixed. They didn't do, but I think they decided compared to the previous experience from the photoframe.
Yeah.
So they assumed that, they already assumed that it will be similar. So they interpolated to HPPH.
Yeah.
Yeah. But that's the good question, because that is the one of the main, effectors. Or fluence rate is more, but they fix it because that will be too much variation.
Well, at that high dose rate, then that will give you things to image with your correlation and reflective spectroscopy. So
yes,
you'll see dynamics with
yes.
that.
That's the things I will try to also future work. So it will be really interesting if we can image it, and also if we can do continuously, which we cannot do it. Optical imaging wise, it doesn't the problem, but the technique wise, like in the operating room, when MD tries to put the PDT dosimetry fiber, you don't want to touch your imaging fiber and just accidentally, sabotage the stuff. So that's one of the main problems. It's not, all cavity is not really accessible nicely for put the optical gadgets over there. So that's the main limitation. Otherwise, you can do like mice imaging, you can do continuous measurements.
Yeah.
That will be really difficult. So I will talk about that things later on. But that may be very interesting to investigate. So for the clinical follow-up evaluation, we have the 3 groups. Like complete response will be the complete absence of the visible lesion or negative biopsy. Partial response, like reduction at least like 50% or more, and non-response will be like less than partial response. And follow-up, the MDs generally do visual inspection. They check the redness, edema, ulceration, necrosis, and also take photos. But for this suspicious case, they can take biopsy again. It will be also interesting to another imaging there, so that they could do correction. So our instrument can do also this part. It will be interesting to implement also. So what we use at the clinic is the combination of these 3 spectroscopic approach. So we time share it in this forms. This is the blood flow part. I'm just showing the 1-channel case. It is 4-channel. So we have the autocorrelator, then single photon counting detector, and laser, long current laser light. And for the fluorescence part, we have the spectrometer. Slave channel is much more sensitive than the master channel. So we excite the fluorescence at 410. You can excite also 660 nanometer, as I said. And also for the oxygenation part, we have a white light source. Then for the probe, that coming to the source detector separations of your question. So we have this 45 degree, we find it very useful, and it should be also changeable. That is for the good contact, and the separations will be fluorescence source and detector separation will be about 800 micron, and white light we chose 1.6 millimeter, and blood flow is about 0.8 millimeter and 1.6 millimeter. Because we have a 4-channel, we had the option to have a multiple distances, but we don't have that luxury for the white light and fluorescence. So this is the one case, I just chose it because it was published, but this kind of results we are getting, just only we have a pre and post results. So for this case, for example, blood flow decreased quite significantly, and oxygen saturation also decreased, and blood volume also decreased. And when we look at it compared to the normal tissue, when we look at it with the HPH, so we have both the concentration and also fluorescence. It is giving similar, but it's not exactly the same. And as you may agree that optical properties affects the results. So on this case, the concentration is a micromolar, but this case is the raw fluorescence. So we have about 2.5 times concentration contrast in the lesion on this case. So this is the STAT3 cross-linking. So the Baumann group would take the biopsy samples and they would analyze, and this is like 19%. This is a very high. I mean, we shouldn't look at the direct linear relationship, but like he will say that even above 5% will be a good sign for the PDT. But we don't know exactly. So we will, for a specific patient population, we need to find the threshold of the STAT3 cross-linking. What is the minimum that is the responder and non-responder? So that is the aim of this study also. But according to him, even 5% and above will be a good sign for the good PDT efficacy. But this is I was saying, so we don't know sure that our changes, optical parameters changes will be linearly correlated with STAT3. But there should be some kind of a threshold, like if you have optical parameters change quite significant, and if it's also related to some STAT3 cross-linking, then that will be a good sign of our non-invasive markers is related to or correlated to biomolecular marker and also clinical outcome. Okay, I want to now show what kind of measurements we are seeing. I'm just showing, this is a crowded picture, but sometimes people want to know, like, what does the individual measurements look like? So that's why I just choose like 5 patients and showing the individual measurements, and like blood flow, blood volume, and oxygen saturation. So what trend we can say is that generally blood flow and blood volume is a bit higher compared to the periphery. This is the periphery region. And oxygen saturation is generally lower, but the lesion has more heterogeneity. It is really heterogeneous tissue. That is one of the most difficult problem compared to, I find it, the breast or something. So, I mean, when you move a little bit the probe away, you have a totally different lesion you are looking. And HPH fluorescences, again, can be affected by the optical properties, so I don't want to make too much conclusion, but it's generally always higher, I mean, most of the time higher in the lesion compared to the surrounding. Now, we found now after, let's say, 25 patients, we wanted to look at the pre-treatment contrast. But my aim is, again, to focus on changes, not the pre-treatment contrast, but I am showing you what we found. That's why I'm showing here. So what we found is that some patients actually doesn't show contrast. And remember that these lesions are not really cancer lesions. They are totally different site, different lesion. It may be mild dysplasia, or there may be some of them is cancer, but some show that high blood flow and some show that low. And when we look at it, here this is the correlation. So in the blood volume, these are the red. These are where the blood flow was high. So there is a kind of these two techniques are totally different, but there is whenever blood volume is high, we are seeing also blood flow is high. So this is kind of also having a good thing, that having multiple parameter investigation. Oxygen saturation, we don't see much trend for the oxygen saturation also, but we should also look at the oxy and deoxyhemoglobin as you are doing it for the breast one. So we haven't looked at this yet. So I want to focus rather than the contrast, but rather than, look at the changes. What we saw is that blood volume changes at different rates, but generally it increases, and oxygen saturation also increases, but blood flow is mostly decreasing. And we saw that the blood flow decreased significantly, much more significantly. Oxygen saturation changes was significant also. Blood volume change wasn't significant, but it is really affected with the lesion type, I believe. So we need to really discriminate after that, divide the groups that we will be provided later on by the clinician which type is, so that's one of the aim, whether we can predict the treatment.
This is immediately after PDT? This is like
yes,
right after?
Exactly. The reason is that I didn't want to measure like 3 hours later, like what is the condition of the patient, I don't know. Like at that operating room, he's staying still. So blood flow is kind of more robust, I thought. Otherwise, after 2 hours, he may be awake and change, and it's very hard to measure. So this is only right after. So like we measured before, treatment is done. So MD looks at us, and then we put the probe, then do the measurement. So it's about a couple of minutes, maybe just. And these are the fluorescence change. Fluorescence always photobleaches. That is one thing. But is it an indicative of the really PDT response? A lot of people are having trouble, like, because always decreasing. So maybe we need to normalize the periphery area. So we will investigate that thing. Periphery is also decreasing, but it is in a less extent. So now I want to come to the also I'm trying to merge to some conclusions, and want to also discuss with you is that one of the issues that we have to do imaging, because we are seeing really heterogeneous tissue here. For example, when we look at the oral cavity for STAT3 conversion, again, we see some trend increasing with the dose, but it is really very big variation. This may be biopsy sampling problems also, because these are already small lesion, and then when the MD tries to grab something, this may be one of the reasons, or it may be really heterogeneity. But I want to point out one case, simple case of the one patient, had 2 lesions. One lesion was at the left lesion. It is very close to the tooth base. It was very accessible, so that you don't have a miss to PDT light treatment. The other one was on the right, again very accessible spot, but it's not the tooth region. But both of them was PDT light dosimetry wise, I think it was okay. I don't think we had an issue. But what we see is that it is like 20-fold difference in the STAT3 cross-linking. This lesion has a leukoplakia. It is like a whitish area, so that it's kind of a shielding. That may be one of the reasons, but we don't know the reason yet. But what we saw in our measurement as a contrast, which I don't want to too much get into the contrast, as I said, but as a contrast, we have the data, so we plotted. So blood flow was lower on the left. Left is the one that high STAT3 cross-linking. Here is we see a blood flow contrast low, but as remember, it is just the underneath the tooth area. It's not like a really like a tissue, a lot of regions. So that maybe that is the one of the reason. Blood volume fraction is kind of a similar in the left. Oxygen saturation doesn't show too much pattern, and fluorescence was higher in that high cross-linking. But the real stuff was we saw the differences in the changes. When we see that actually the left one who is responding well, blood volume increased, oxygen saturation increased more, blood flow is increased more, and photobleached more. So we see some contrast with the changes. So I just want to point out that I think the main players will be the changes on this kind of problem, clinical problem. Yes.
The blood flow on the left side went up, and then when you were looking at all of your blood flow results, it seems like they're going down.
Yes.
For most of those.
Yeah, most of the years.
Yeah.
I mean, it is hard to, I cannot say because I mean the best thing to look at how this continuously changes. But the best thing will be you don't want too much blood flow decrease. You don't want, I mean, looks like there will be, blood flow decrease. But if it's increased, I believe it is a good sign. But if it's not too sharply decreased, it will be good. Also, and you don't want too much blood flow decrease.
It
But
makes sense. I was just trying to reconcile. You show increase in blood volume fraction, but you're showing a decrease in blood flow. You see an increase in saturation, which is good. That's what you would expect if maybe there's a flow increase, cells are dying, there's less extraction, so you would see an increase in saturation. And so the flow, not going in the same direction.
Yeah, flow is very flow is really very quickly changed. So it would be interesting to actually measure it, let's say, after 2 hours.
Yeah.
That will be more indicative of the response, I believe. But, I mean, it will be really jeopardize also the measurements. I cannot really measure the guy like 2 hours later and correlate. It is almost impossible. That is one of the problems.
And you have the oxygen and the deoxygen.
Yeah, I have everything there. I mean, we will look into that. Yeah, that's I will look. That's I was saying to. I mean, all the analysis done by my student, so I haven't done anything yet. So this is, as you saw the equation, it's more like a bias because we took from the PDT papers. They generally try to fit blood volume fraction and blood saturation because when you are fitting, we can really say that blood saturation will be between 0 to 1. Blood volume fraction is also, in the head and neck lesion, about 2% to 4%. That is the reason we choose that equation. But from there, you can come back to the oxygen deoxyhemoglobin part. In Arjun's lab also, we were fitting like what you are doing, like oxy, deoxy. But right now, we find this, just convenient. But still, you can go back and forth.
With the blood volume fraction, are you assuming a certain hematocrit value?
I haven't, no, I think I'm directly fitting it. Yeah, blood volume fraction and this is just blood volume fraction and oxygen saturation, the parameter to fit.
I see.
Yeah, that's a bit, it was a bit different for me also from the previous experience. As a summary, I will say that significant changes we are seeing within 15 minutes. Early changes can be predictive. We don't know. And assessing multi-parameters are really useful because we can look at like blood flow and blood volume and oxygen saturation, deoxy part, and try to look at the metabolism, how it's oxidative metabolism or consumption rate, how it is related to. And like you guys did it in breast case, like which parameter will be the most sensitive to the changes, or which parameter will be the predictor, or close to the predictor. So that's we will look into that, and we are looking into that. So the aim is to that also will be having a statistically significant data set. This is important because PDT is relatively new, but you need really clinically accessible patients. So to be really accepted in the clinical community. Now, motivation for the improvement. That's I want to discuss with you is that so there are relatively high recurrence rate, 80%, but it is still good as we discussed before compared to the chemo, etc. But I mean this can go much better than 90%, and because if we can improve the dosimetry, and several patients retreated in our experience, but from the previous study, which we optimize also the dosimetry. So in this case, we expect in this new study it is better, but there are several patients with large spread lesions. This is the multifocal issues. Like some, you don't know the really it's not a solid tumor. you don't know how much it's spread. So it is the imaging will be really valuable on this kind of cases. So there exists intra and intra heterogeneity. Imaging again will be valuable. We did only pre and post measurements. It will be really useful if we can continuously monitor. So there is a need for the improvement. So one thing is what we measured is before. I mean, we also measure it, but like autofluorescence part 500 to 600 nanometer case, and there is also HPH part as a red fluorescence. What we see is, and what the other people already did it, is that like HPH contrast will be look like this, about 2.5 fold or 3 fold if you are lucky. But when you divide the HPH divided by autofluorescence, what we see is a much better contrast. So this will be good for the visual guidance. And I just given some examples between some patients, 5 patients for between the lesion versus periphery. So this ratio imaging can be useful. We did this. So Wilson group is pretty much worked, and Europe group also worked, Macrobot group. So PP9 imaging they applied quite well. So you can get semi-quantitative analysis. So let's say, for example, on this is the camera-based imaging, planar imaging. So you have the tumor around here. It is the autofluorescence will low on the lesion. This is the red. And then when you ratio it, you get rid of some kind of artifacts also, like semi-quantitative, and you localize better the lesion. So this may be the way to go for the image guidance. So this is, I want to basically work on it. So what you can do is that you can combine with the imaging. This is the rigid endoscope, Karl Storsvold cell. So you can combine with the spectroscopy part, and you can try to have the measurements where you want to take the biopsy one. So this can be also moving spots, so that you can get the spectroscopic measurements. So you can get a rigid handheld stuff, so that during the PDT this can be very stable. And another thing is, this was a bit interesting because when I asked to my students something to plot, he misunderstood, and he plotted this thing like lesion fluorescence divided by autofluorescence with respect to STAT3. This was just accident, but there is more correlation we saw it. I don't expect any physiological right now, any interpretation, but I think what happened is that some correction factor kicks in. So what I'm trying to say is that if we do something like a modulated imaging or something quantitative, if we correctly quantify the fluorescence content, maybe we will see much better correlation between the STAT3 versus our measurements. Again, this is, I put about some lines so that this will be the contrast with HPPH, but when you have the division, you have much better contrast. And I saw with this from Wilson group, who actually the inventor of the, I would say, I think the modulated imaging, if I am not wrong, they applied actually the rigid endoscope, and they showed the feasibility on their finger, so on the laboratory environment. So this is the scanning 2002. So they looked at I think this is like about a 1.4 millimeter depth of field, so that they can focus at different depths. So this is the regular imaging versus the modulated imaging. So if we have the instrumentation like technical skills, maybe this way, the modulated imaging may be also today, so we can do. I mean, also after that, there are like OCT people here. They can scan maybe like more localized area. That may be another, or microendoscopy can kick in on this PDT with the oral cavity related area. The another thing I wanted to say is that heterogeneity always the one of the main player for the PDT recurrence rate or failure of the PDT. So when you have a lesion with the, for example, fluorescence, then after PDT, you may have a different distribution of the fluorescence. It may be because of the maybe heterogeneous distribution of your light, or it may be the lesion itself. So you need to investigate maybe like a BC, breathing chance was doing, like histograms, plotting. So whether the heterogeneity is changing really. That's one way to look at it. And interestingly, Teresa Bush in UPenn investigated that PDT itself can create heterogeneity. Even you have a homogeneous lesion, if you have too much light, this is PDT 75 milliwatt per centimeter square versus 38 milliwatt per centimeter square. So this is, you would say that low and slow case. You don't have that much heterogeneity in EF3 binding, hypoxia. But even blood flow, when she had the different depths, and for the high fluence rate, she sees that as soon as PDT light is on, when you look at the standard deviation, it is much higher during the PDT. So she concluded that actually you need to adjust your fluence rate according to the drug dose and according to how much your light is on. And now the field is going to the interstitial head and neck PDT treatment, where you want to look at the deeper tumors, where like more than 5 millimeter depth. So most of the now base of tongues, for example, a lot of people are now coming to the clinic with the deeper and larger tumors. So that is one of the options. So Europe is always ahead of us. So they already did some clinical work. So I am seeing that Europe is more spending time on money on the PDT. So this is one of the review paper you may see. So future direction will be we can incorporate the 410 nanometer and 660 nanometer excitation. Ratiometric imaging should be implemented. Potentially you can do also speckle imaging, blood flow, or narrow band. You can have different filter sets to look at the blood volume and blood oxygen saturation. Or modulated imaging can, if we can, I don't know the feasibility, but fluorescence, blood volume, and blood saturation. It would be nice to look at also heterogeneity mapping. We need to do continuous measurements. Maybe we can put some treatment fiber inside the endoscope, or interstitial PDT is also another way to new field for the PDT. So I want to conclude my talk by acknowledging and thanking to our collaborators. In the clinical side, Dr. Rigual is the surgeon who does the treatment. Michelle Cooper is the nurse, and Ken Camel, Adam Sumlin, and Brian is the laser engineers. Balnier, I didn't show the Dr. Balnier actually, I didn't show the blood analysis, but he does the blood analysis. And we are trying to correlate also with our non-invasive measurements with the blood analysis. Dr. Ravindra Pandey is the drug development guy, so he developed different types of drugs, PDT drugs or imaging drugs. And Dr. Henderson and Baumann will be investigating the PDT mechanism. We are the core, optical imaging core. So my student Dan Rohba and Vizong Mo was my postdoc, and Dr. Foster was also in the PO1 from University of Rochester. And I want to also thank for the PO1 grant and also our RPCI Startup Fund. Thank you very much.